Basically, you and your partner got called to a private residence for a 65-year-old female with shortness of breath. Now, before we start, let's take a second and think about the differential for shortness of breath. It's pretty broad, but what are 10 causes of shortness of breath? There are a million answers, but these are some of the big ones. For me, these are the ones that are kind of the most common ones that I think of, right? And your goal here is to eliminate that list one by one, right? Can the patient speak with a normal voice? Did they choke? Do they have bilateral lung sounds? What are their lung sounds? Is there rales? Is there rhonchi? Is it bilateral? Is it unilateral? Do they have a fever? Are they complaining of a productive cough that kind of led up to the event? Check these things off one by one. As an EMT, you learn like sample history and OPQRST and all of that. And sure, that's a good start, but you need to know the different conditions and then how to eliminate them from your differential. And that's how you create a flow with your interviews and your assessments. So we pull up to the house, and inside we meet Martha. So you find Martha laying on the couch. She's sitting up. She's a 65-year-old female with a history of mild COPD. She has type 2 diabetes, hypothyroidism, and hypertension. Basically, she had 3 to 4 days of non-productive cough, stuffy nose, mild fever with some muscle aches, and just kind of general malaise, right? Or malaise. Her grandkids were over the house over the weekend or for the holidays. And they're, your typical school age kids, right? They're like little petri dishes. Um, and she was seen in urgent care where kind of everything was checked out. She was okay. She was sent home. Uh, but today, she woke up feeling a lot worse. She developed severe body aches and chills and kind of a newly productive cough. And her husband called 911 after Martha couldn't catch her breath when she went to the bathroom and came back. And just that amount of effort, she hasn't been able to catch her breath in over an hour from that. So, from a physical perspective, generally she just kind of looks sick, right? She's anxious, she's alert, but she's lethargic. She has with these weak radial pulses. She's tachycardic. Her cap refill sucks. It's like greater than 3 seconds. Uh, she has a productive cough. She has an increased work of breathing. She's tachypnic. She's got rales and rhonchi and kind of that middle right lobe. She's warm. She's got some mild diaphoresis, poor skin turgor. She's sick, right? She looks sick. And your partner grabs some vital signs for you, and she's tachycardic, she's hypotensive, she's tachypnic, her SpO2 is low, she's hypoxic, she has a fever of 103.5, her glucose is a little high. She's sick. So let's take a second and think about those differentials, right? What are you leaning towards now? To me, I'm thinking kind of an infectious route, specifically a kind of severe pneumonia. So let's talk about that. So, what is pneumonia? Pneumonia is a respiratory infection characterized by inflammation of the alveolar space and kind of the interstitial tissue of the lungs. It's the leading cause of infectious death in the Australia's world. It's the eighth leading cause of death in the world. The primary diagnosis for 1.5 million ER visits in the US alone. We see this stuff all the time. It's a bread and butter kind of thing for us. And there's a bunch of different kinds of pneumonia and several ways to categorize it. So it's believed that most pneumonia is actually viral. However, bacterial is also common. You can get fungal, you can get parasitic, you can get aspiration pneumonia. There's a whole bunch of types of pneumonia, um, but those ones are a little more rare. The specific pathogen actually isn't known in the majority of cases. So around 60% of the time, they have no idea what caused it. So when we think about etiologies and pathogens and stuff like that, there's multiple ways to kind of classify this. So pneumonia is clinically differentiated into typical and atypical based on symptomatology, and that kind of helps to narrow down the source when it comes to treatment. It's often categorized as community acquired or hospital acquired as well. There's kind of different pathogens that tend to be associated with each one, and a subset of hospital acquired is something called ventilator associated pneumonia, which affects around one third of mechanically ventilated patients in an ICU. So let's take a look at Martha, right? I'm blazing through this stuff because one, it tends not to affect us in much, and two, just for the sake of time, right? I'm just going to kind of tell you the story here. So Martha has a typical community-acquired pneumonia. Specifically, she has a bacterial pneumonia. Her typical pneumonia or atypical pneumonia is characterized by kind of a rapid onset, and it tends to have more severe symptomatology. And hers was caused by a bacterial infection, right? You wouldn't know that in the field, but here you go. So you could also classify pneumonia by its location on a chest X-ray. We don't have those in the field, also, but don't worry about it. For those wondering, Martha has a low bar pneumonia on the right side. So Martha demonstrates most of the typical findings in a severe pneumonia, but there can be like a million other things, right? You can read the list just as well as I can. There's a million of them, but just the big ones, like these are just the big ones, and poor Martha has like all of them. From a patho perspective, pneumonia causes two things. So hypoxemia and sepsis. And yes, there are other answers, but those are the two big things that we care about. So, how did Martha get a pneumonia? The short answer is her grandkids, right? Uh, she's 65, so on the older side, right? She has a few risk factors, with the big one, COPD. Basically, your body has a bunch of defenses to keep your lungs clean, and Martha's didn't work. So, she was sick with a viral infection from her grandkids. Basically, that viral infection got to her, and it weakened her immune system enough where a bacterial infection took over also. So basically, all of a sudden, bacteria from the back of her throat that would normally get kind of caught up and stopped basically sneaked its way into her lower airways that were already kind of angry from the viral infection that she already had. It's kind of an opportunistic bacterial infection. Basically, bacteria gets in two ways. One is aspiration of mouth flora, and two is inhalation of tiny particles floating around in the air. It's usually the insulation part. And basically, the bacteria sets up shop and starts kind of beating up both surrounding lung tissue, and the body doesn't like it. So you get fluid dumped into the affected alveoli, which just kind of grows more bacteria, and that spills into neighboring units and kind of spreads. And to fight it, the body tends to send neutrophils and other stuff into the lungs. And eventually, macrophages join in, and it turns into this giant mess of gunk that fills up the airways and bronchioles, and you start coughing it up, and you know, gross, right? So let's focus on the hypoxemia part. Does Martha have evidence of severe hypoxemia? She does, right? So what's causing that? Essentially all of the junk in her lungs, right? So we call that a form of VQ mismatch. So you have all these white blood cells, fluid, proteins, etc., in the alveoli and the lower airways, and it's causing this big consolidation in the lung field. And here's the thing: O2 can't get past that, right? So we have whole videos on this on the website and stuff like that. But real quick, V is for ventilation, Q is for perfusion. Normally, the lung wants these two things to match, right? It wants to send lots of blood to the areas that are well ventilated, and less blood to the areas that aren't. So in VQ mismatch, that gets messed up. So now VQ mismatch exists on kind of continuum, right? So there's two big extremes, but it's usually somewhere in the middle. Two of the extremes are shunt and dead space. So in shunt, you have blood going from the right side of the heart to the left side of the heart without being oxygenated due to a lung unit issue. In dead space, you have lots of O2 in the lung, but the blood isn't coming through, so you just kind of are ventilating dead space, right? To simplify it, a shunt is an alveoli issue, and dead space is a circulation issue. In severe pneumonia, you have a big shunt. You have this whole area of lung that can't oxygenate because the airways are all gunked up, especially with a big low bar pneumonia like Martha's. And this is why these patients get short of breath and hypoxic and have increased work of breathing and all of that stuff. Um, but this isn't Martha's only problem, right? Right? What was that other thing that pneumonia can cause? Sepsis. Is Martha septic? She sure is, right? Martha's very septic. And not only that, so not only does she have a pneumonia and this severe like hypoxemia and stuff like that that comes with that, she also has a severe sepsis. So what is sepsis? The definition changes every now and again, but currently, sepsis is basically a syndrome characterized by life-threatening organ dysfunction caused by a dysregulated host response to infection, like pneumonia, or a UTI, or a renal infection, or whatever else, right? Sepsis is really common, right? It's the most common reason for ICU admission in the United States, and it's actually 32% of all ICU beds in Europe, right? It's something we see all the time, and there's thousands of causes of sepsis, but the most common is actually pneumonia, which is what poor Martha has here. So there's a subtypes of sepsis called septic shock, and this is a distributed form of shock, and it's defined clinically as hypotension requiring vasopressor support to maintain a MAP greater than 65. Or, if you want to look at lab values, it's a serum lactate greater than 2 without evidence of hypovolemia. Basically, if the septic patient doesn't respond to fluids alone and is still hypotensive or still has a positive lactate after initial volume resuscitation, we can consider them to be in septic shock and they require vasopressors. So there used to be something called severe sepsis, which was its own like little category, and this term's no longer used. Basically, it was sepsis with evidence of organ dysfunction. They kind of got rid of it back in 2016 guidelines because it was kind of redundant. So, how do we define organ dysfunction? Because that's kind of a big part of the definition. And I could be vague and tell you that, like, use clinical signs and symptoms and judgment, etc. But there are actually scores out there to help us define it, and particularly in sepsis. And there's a bunch of them, right? There's SIRS, SOFA, QSOFA, NEWS, MEWS, etc. The guidelines recommend QSOFA and SIRS kind of most often, but the evidence for both is kind of shaky, to be honest. SIRS, systemic inflammatory response syndrome, is just inflammation, right? It could be inflammation from anything, not just sepsis. It's kind of too vague. QSOFA is probably missing some people, and it tends to do really well capturing like really sick patients, but maybe misses some of the borderline cases. None of these scores are perfect. So because those two are the kind of the most common to use, we'll use those two on Martha here. So here's QSOFA. You need greater than 2 points. 2 points or greater to have a positive score, and Martha has a 2. So she is positive on the QSOFA score. And then here's SIRS, right? We need 2 of these also, and there it is, right? She has 4. Martha's obviously septic, and she's very sick, might I add. But why? How? Right? What does sepsis actually do? What makes these people sick? This explanation will by no means give the topic justice. I'm just kind of running out of time. So, sepsis is a really complex process involving both infectious organisms and the host's own immune system and the response to that pathogen. It all starts with an infection, just like Martha's pneumonia, right? And basically, there's a pro inflammatory response to this infection, and that's to help fight it. But there's also a bunch of pro-inflammatory mediators that are produced, things like tumor necrosis factor, interleukins, etc. And these things recruit more mediators to the area. They call white blood cells over. They change some physiology around it to make kind of stuff work better. And in the one area of the infection, that's great. But the jam here is that the host's immune system becomes dysregulated, and what is supposed to be a localized thing in just that one lung section becomes a body-wide response, and that's really sepsis, right? It's the effects of that pro-inflammatory, anti-inflammatory imbalance causing the signs and symptoms that we see in sepsis. And that's kind of the gist of it anyway. There's like entire textbooks describing this stuff. So these dysregulation of inflammation causes a bunch of issues, but the ones that we see and care about are the cardiovascular ones, right? So basically, we get vasodilation slash vasoplegia, we get myocardial dysfunction, altered microvascular flow, diffuse endothelial injury, and then the big jam that we actually see and care about is the vasodilatory part, right? It's the vasodilatory shock because all the blood vessels are dilated and all the capillaries get really big and leaky, and you get fluid everywhere, right? This ultimately leads to a decrease in venous return and then cardiac output and then blood pressure. So this can lead to end organ damage, kidney injury, ARDS, coagulopathy, DIC, a bunch of other problems. So from a clinical features perspective, um, there's a bunch of them, right? You can read just as well as I can. Martha has at least malaise, tachycardia, fever, hypotension, hypoxemia, and hyperglycemia. And we can assume that Martha has more also. We just haven't tested for them. We haven't done a lab. She could be in DIC. She could have a thrombocytopenia. She could have acidosis. She could have other things going on. These are just the ones that we know of so far. So how do we treat sepsis? There are 3 big pillars to sepsis care. One is hemodynamic support, which is like your O2 fluids vasopressors, and then the other is antibiotic therapy. And then the third is source control. In EMS, we kind of live in the first 2. We live in supportive care, and in several places in the country, actually, we initiate antibiotics in the field for suspected sepsis. So let's talk kind of hemodynamic support first. We'll use Martha. So Martha gets the standard safety net interventions, right? She gets IV O2 monitor, and her set's in the 80s, so we'll give her some O2. We need to get a line, right? She's hypotensive. Let's say you get a line, and now you want to hang fluid. How much fluid should Martha get? The guidelines say 30 mLs per key in the first 3 hours. That 30 ml, I'll tell you, is just kind of a random number. Like there's really no science behind why it's 30 mLs, but there you go. It's 30 mLs, and it's in the first 3 hours. The days of starting like 2 lines and getting 2 liters in the first 20 minutes are over, right? We know she has a fluid deficit, yes, but we also know that only around 50% of hemodynamically unstable patients will respond to fluid. We also know that too much fluid too quickly can worsen the cardiac output. We also know that, hemodynamic response to fluids is short lived anyway, right? Because of the whole third spacing concept. So it only works for like 15, 20 minutes. It's not fixing the problem. The problem is vasodilation, right? The fluid doesn't fix that. You're filling the tank before you squeeze the tank, and there's that whole argument. And I get that, right? Does fluid help? Sure. Does she need some? Absolutely. But not all at once during your ambulance ride. So let's say Martha is 70 kilos. How much fluid should she get in the first 3 hours? So 70 kilos times 30 mLs per kilo is 2100 mLs, right? So a little over 2 liters. Now, this can be normal saline or LR. There used to be a big push for LR versus normal saline. Normal saline being associated with like hyperkalemic metabolic acidosis, and LR is preferred because of that. And then the basics trial came out in 2021, and we're not positive how much that LR makes a difference. I personally still give LR if I'm going to give a large volume infusion, but it you may not have to, and it may not matter as much as we think, and normal saline may not be as inferior to LR as we thought. Hopefully, there'll be more to come out of this because this is a really interesting study, but it probably needs more data. So here's what I like to do. I usually give a bolus of 250 to 500 mLs. And when I say bolus, I mean bolus, right? Dust off the pressure bag, put the pressure bag on the thing, and give it over like 10 minutes, right? So after a 250, 500 bolus, you should see some meaningful improvement, right? Is her blood pressure going to be fixed? Absolutely not. But you should see some positive change, and that's what you're looking for. Even if she remains hypotensive at that point after like 500 of fluid, that's my personal trigger to start vasopressors. So let's say we give Martha 500 ml bolus and she remains tacky and hypotensive, right? Now what? Pressor time. So what is the primary goal of vasopressors? They obviously press stuff, right? They squeeze. They squeeze the blood vessels, right? More specifically, they increase venous return by restoring something called the stressed volume. That's what vasopressors actually do. So, what is the first sign vasopressor that we would use in this patient in septic shock? What drug do we want to use if you had all the choices? Norepi, right? Norepi is the recommended first line agent in sepsis by almost every major guideline and society. Uh, Norepi is mostly an alpha 1 drug, right? It's got some beta 1 activity also, but basically it's really good at squeezing pipes, and it gives the heart a bit of a kick too, as a kind of a secondary effect. Specifically, Norepi is really good at squeezing the venous system, which is how you get your venous return and cardiac output benefit. Um, the venous system tends to be a little more sensitive with our pressors before the arterial system, so you usually get venous stuff first. So we get Martha and Sonorepi. We get a standard dose. This will depend on your protocols, whether you use like weight-based or standard-based. And then we're going to titrate it, right? And what are you titrating to? What is your MAP goal in septic shock? The MAP goal should be anything greater than 65, right? And I tend to keep it lower at 65, right? When the MAP falls right below organ's autoregulatory threshold, uh, organ blood flow decreases linearly, right? It tanks down. Autoregulatory ranges of the heart, brain, kidneys is anything greater than a MAP of 60. Any MAP less than 60 is likely to cause ischemia and ultimately organ death. In patients with chronic hypertension, they may need a little bit more MAP, than that can be considered separately. But generally speaking, in sepsis, the MAP goal is greater than 65, right? Higher goals are actually associated with more pressor use and more arrhythmias. So they did a study comparing like 65 to 75, I think, or like 60 to 65 to 70 versus like 75 to 80 or something, just to give them a little more blood pressure. And they found that it was associated with more arrhythmia. So anything above 65 is fine. Keep it at 65, 65, 70. You don't have to go higher than that. So let's say we've maxed out our norepi or we're getting pretty high on norepi. What else can we add? So you have the ability to add pressors, right? Mixing them is recommended once norepi reaches a certain dosing. Usually the dosing is greater than 30 mics per minute or greater than 0.2 mics per key per minute. The VAST trial, VASST, VAST, I think, was a randomized trial that basically randomized patients with sepsis to norepi group or norepi plus vaso group. And there's no mortality difference between the two, but the subgroup analysis demonstrated survival advantage with the vaso group in patients who are on norepi. So basically, vaso is recommended as the second line pressor in septic shock. Not all EMS can do this, so if you can't, no worries. But you would also consider steroids at this point when you go to add your second pressor is when you'd like pull the trigger for steroids. So, what if I don't have norepi, right? A lot of EMS agencies don't carry norepi. What else can I do? Just use a different pressor, right? Norepi might be the ideal pressor for sepsis, but like other pressors will work. Um, the jam with norepi is that it requires a pump to be given, and unlike the other pressors, which that can limit its use in EMS, epi and dopamine are okay, right? Um, I prefer epi over dopamine personally. Um, if I didn't carry norepi, I'd probably just give epi. Um, but dopamine, if that's all you have, that's fine too, right? Um, Dopamine gets a bad rap, right? And there's some reasons for that, right? They looked at septic patients almost specifically. I think it was 2016, where they did this big meta-analysis where they looked at all the vasopressors. They're like, which one's the best? Which one should we pick? And basically, they found that all the vasopressors worked. With this little asterisk that was like, by the way, dopamine, even though it works, is associated with an increased risk of tachyarrhythmia. And that was it. That's why dopamine gets a bad rap. It's literally just because it can cause some tachyphylaxis. That's it. It'll work in a pinch. It's just not ideal, right? Because if you have other drugs that'll also work and those aren't associated with tachyphylaxis, you're going to pick those ones, right? So in a pinch, use dopamine too. I just prefer epi. Ideally, you would use norepi. Antibiotics we're not going to go super into here because most agencies still don't carry them, but there are EMS agencies that do. Basically, your initial goal in antibiotic therapy is kind of you usually give 2 to 3 different types of antibiotics. The first one is kind of a broad empirical antibiotic therapy, and it covers your relevant like gram-negative and positive organisms. Basically, you'll get cultures before you give that, and then you can start to like narrow down your choices of antibiotics. It's largely determined by like the suspected source of infection, the patient's immunologic status, and whether the patient's like at risk for drug resistant pathogens and stuff like that. Usually it's a 7 to 10 day course of antibiotics. That's usually fine. Early antibiotics is key though, and that's why EMS started carrying them. The average delay in the ER is 120 minutes before antibiotics are given. Even though the goal in like every major guideline is less than an hour, the average is 120 minutes. So they found that there's this big New York City study that the odds of in-hospital mortality were increased by 7% for every hour delay in antibiotic administration in patients with septic shock. So a bunch of hospitals got together and like, well, we have these EMS agencies who already brought the patient in and already told us it was septic. So why don't they just give it? And they're like, oh, yeah, that makes a lot of sense. And thus, EMS started carrying antibiotics. Look at that. And the last thing is source control. This could be things like surgery. This could be removing drains, removing catheters, etc. Right? If the patient has a UTI, you should take out their catheter. If they have bacteremia, you should take out their PICC line. Um, if they have a big, intra-abdominal process causing sepsis, yeah, take that out surgically. Source control, right? Not something we're going to do, but something that the hospital's going to do. All right. So you put the patient on 100% O2 via non-rebreather for hypoxia. She ultimately needs high-flow nasal cannula at the ER. The jam with shunts, they don't really respond well to oxygen therapy, said the jam. She gets 550 mLs of saline during her trip. It's about a half-hour trip. She got 2 lines, norepi titrated to a MAF of 65. You did a great job there. Then he arrived at the ER. In the ER, she was intubated for her hypoxia. She was taken to the ICU, and then she was discharged 3 weeks later, doing fine. So that ends the case, but before you go, I recommend everyone check these 3 articles out. One is the Sepsis 3 guidelines, the 2023 Sepsis Septic Shock in Adults for more emergency specific, and then the Surviving Sepsis Campaign articles. Read these 3, they're all available online for free. They're going to give you a super solid framework and foundation for septic care. So I recommend that you go and read all 3 of these papers. Honestly, like half this presentation is based off of these 3 papers. So go read those for yourself. Well worth the read. So this was a super sick patient who had some big problems, septic shock and pneumonia that caused it, right? So thanks for watching. Stay tuned for the